Thank you. First of all, good afternoon, everyone, and I would like to thank Dr. Subrato and his team for inviting me here. From the genetics, we now move on to the clinical side of things, which I think is very relevant to our country. And what I'm going to speak today is about height prediction models and how they can be used in our clinical situation. So I have divided my talk into largely three parts. Height prediction, we are talking about adult height prediction based on bone age, those which are not based on bone age, and two together. So let's start with our very basic pediatric endocrine training when it comes to height prediction not based on bone age. So we all know the target height, and you must be wondering, why am I talking about it to such an august audience who probably have by-hearted the mid-parental height formula several years ago and continue to do it every day? Because there are caveats in it. And if you look at it, there is this factor of 13, which is the average difference between man and woman in most countries. But in a country like India, especially in rural setting, this formula may have to be changed to plus minus 10. The reason is that's the average height difference between a man and woman, and we published this paper in 2001 in Journal of Pediatric Endocrinology and Metabolism. But let's for time being say that this model is perfect for the urban Indian, because indeed in the IAP 2015 growth charts the difference remains 13. But then there's another way of looking at it. That's the mean parental height standard deviation score. That's father's height SDS plus mom's height SDS divided by 2. And then there's something called corrected target height SDS. Now this is a paper by Tim Cole and Michael Hermanusson, where they have said that if you multiply the mean parental height by 0.72, you remove the bias in extreme stature situations, too tall and too short. So as I said, this also corrects for the secular trend. Now here we are in India, and we are currently just looking at this, is if you look at migrants to cities from villages who live in slums, they are much shorter than their children. In fact, the difference can be as much as 15 centimeters between two generations. So how do you correct for that secular trend? Is there a formula that you can use? And I have shown you an example here using the three equations that I showed you earlier. And here you can see the Tanner standard equation will give you 162.7. Cole's and Hermanusson's, Cole's target height SDS will give you 162. And when you use the Michael Hermanusson and Cole equation, it will give you 166. So it actually corrects for the secular trend. And then, after having added a lot of data to this equation, we realize that to correct for the secular trend in Indian situations, you probably need to add about 3 centimeters to the derived target height. And also, there is one more method of correction, that when you have been using old growth charts and you move on to the new growth charts, then you should use this correction of the target height minus the population mean, but you need to use the updated growth charts here, growth percentiles. And then you would get a number which is 167, which is 5 centimeters more than what the standard J.M. Tanner's equation gives. So here is a situation where we can now correct for the mid-parental target height, which I think we should at least make an attempt of in our clinical practice, so that adjusting for the mid-parental height in a short kid becomes relatively more relevant. Whenever I go to a pediatric orthopedic clinic, they always wonder and ask me this question, that I have got a kid who has got these bent knees, and I now want to do a procedure where I want to put clips onto the growth plate. Can you tell me how much more is this kid going to grow? And then I say, I need a bone age. But they say, why? We have been practicing this for years and it works beautifully for us. So this is another method of prediction of adult height called the multiplier method, and you would find these charts in a lot of pediatric orthopedic clinic. And all that they do is something that you all learned as pediatricians, is whatever is your height at 2 years, double it, and you would get the final height. But that's only true for boys. If you look carefully, that's largely true for boys around the world. And I fitted these into the IAP 2015 growth charts, and indeed our numbers are different. It's actually 1.86 for boys at 2 years and 1.67 for girls at 2 years. So yes, you can definitely use these methods, and you just heard Professor Lars saying that 65% of your height is going to be genetically determined. I want you to remember one important thing here, that all these equations are based on the 50th percentile line. And we as pediatric endocrinologists do not deal with the 50th percentile line. We are dealing with third or below third. So you have to take all these equations with a pinch of salt. This is Professor Charles Brooks' method, which I was taught at Great Ormond Street years ago. So if this is the height of your child, you just project it on your most updated country-specific charts, and then you do a bone age and you project it further. And largely, the kid is going to get height between these 2 points. And it largely works, because 60% is going to be genetic, and there's a phenomena of biological regression to the mean, as we all know. So tall parents don't necessarily produce tall children. And the converse is also not true for very short people. So there is a phenomena of regression to the biological mean, and therefore this method also largely works in clinical practice. Then moving on to my next thing, height predictions based on bone age. Now, as we know, there is Bailey and Pinu method, there's Tanner-Whitehouse method, and recently there's Gilsan's and Ratib method. So I want to demonstrate these three methods with an example. I've got an example of a boy, and as you know, these are the equations, and I'm sure many of you have gone through this, so I won't go into the details of that. But I again want you to look at these constants here. There's a 97 constant in the boy's equation, and there's an 85 constant in the boy's equation, and these are based on English population. So when you apply these models to India, I think you should have a scale down factor. What it is, I don't know, but I guess it would be about 2 centimeters in girls and 3 in boys. Grulich and Pyle method, this was the Bailey and Pinu's tables, and you know, they looked at it in a simplistic way. They looked at it that what percentage of growth is complete at what bone age, but we must all remember that these were designed when computers were not there. So I think it's highly acceptable and highly commendable as to what they did, as to the percentage of growth at 10, and you multiply it by 100 and you get the final height. Gilsan's and Ratib method, now when the computers are available, actually corrects for coefficient at various ages for bone age as well as for current height. But the important thing, as I find in Gilsan's and Ratib, is that it gives you a different formula for post-menarcheal girls in whom the bone age is not that advanced. That's the only method that seems to give it. So this is an example where using the using the Grulich and Pyle method, your predicted height is 165. Same child, using Gilsan's and Ratib, the predicted adult height is 162.7, and using Tanner-Whitehouse, it's 158.5. Exactly same patient, same radiograph, same information added. The reason why you get different numbers here is that both Gilsan's and Ratib as well as Tanner-Whitehouse 3 methods have Asian bones included in it. And therefore, I think TW3 in particular is more relevant to a country like India. Now the models based on both parents' height and bone age, and I think there's only one, and that's Bone Expert. Now there are people here in this audience who do use bone age, and I can see Anurag here. So Bone Expert actually it removes the subjective bias and gives you an objective number when it comes to bone age. But if you look at the internal algorithm that tells you about the adult height prediction, many factors have been given different weightages. And therefore, it actually gives you a much more objective and a far better prediction than most of the methods that we use using subjective analysis. And it also lets you add the parent's height, the current height, bone age, chronological age, and then it would draw this beautiful diagram for you where you can see the age of pubertal spurt. So I felt, going through these models, that this is perhaps one of the more complete models when it comes to analysis of final, or I can't call it final height, adult height, because your final height is actually less than your adult height, just before you enter the grave. So as I said, the adult height prediction models we use were developed from normal and not very short and not very tall children. Height prediction in short children will overestimate the adult height, and in short or tall children, a delayed bone age will increase the error of height prediction. So I think bone age gap from chronological age, if it's wide, your adult height prediction is going to be wrong. And of course, it's not reliable in certain conditions, such as the skeletal dysplasia, some syndromic children. You heard Professor La speaking about the agrican gene, and I think that's where there's a relentless progression of bone age, and you aren't going to overestimate the height of the child. Now, disease-specific height prediction. Adult height prediction methods in idiopathic short stature and constitutional delay of growth and puberty, you tend to overestimate the adult height. Across short stature population for Bailey and Pinu, this overestimate is about 2 to 4 centimeters. And all models somehow are more accurate for girls than boys, because I think the pubertal growth spurt in boys is more variable. Important for us to remember is that you cannot do bone age using Tanner Whitehouse and use Bailey and Pinu tables. Whatever method of bone age you use, please follow the same method of prediction. But if you look at normal children, like athletes, who are fit, healthy, normal, then there's an amazing correlation between the bone age, the chronological age, and the adult height that you predict from equations. So in normal children, growing around 50th percentile, all these equations work beautifully. Now here is another case. A 15-year-old boy, growth hormone deficiency. Now I'm moving to the disease situation, where I'm going to talk a bit about prediction models in disease situation, particularly Professor Ranke's model. So here's a 15-year-old boy, growth hormone deficient. His height is 120, weight 29. Target height is 168 centimeters. His bone age is significantly retarded, as you can see. His bone age is 10 and a half. So let us put this in Professor Ranke's equation. Now what's important, and why I love these equations designed by Professor Ranke, is that they do not ask you for information like IGF-1, bone turnover markers, etc., which are very expensive in our country. These are clinical parameters. Most of the times, you would be able to get most of these parameters. So I have fed this to this equation, and I get a prediction. In the first year treatment with growth hormone, this kid is going to grow 12.2 centimeters per year. Now, had the same child been older, so the patient that I showed you is the second line here, 15-year-old with the details I showed. He's only going to grow 10.6, but had this child been 10 years old, the same kid has a predicted height gain of 12.2 centimeters in the first year of treatment. So just because he is younger, he is going to respond better. And this clinical model of prediction will tell us that. It has been a long journey, as you know. There are lots of prediction models that you get. There's Qubix, there's Gothenburg, and this Cologne model. But these two models take into consideration biochemical factors as well. I think I showed you this, but in the background, there is a lot of weightage given to various factors in that model. And this table gives you an idea of the Qubix prepubertal prediction model and what factors have what weightage and what correlation. it explains about 60 to 70% of the predictions that you do. Now, in the last 5 minutes or so, I would speak on a oxology-based software, which is internet-based, which is made available to us by Pfizer, and that is iGrow, and this is an internet-based oxology software that will draw growth curves for you, and it will also show you the predictions and help you to decide the dose of growth hormone. So in iGrow, you have models for isolated growth hormone deficiency, Turner syndrome, and SGA. And in IGHD, you have first-year response, subsequent response, total pubertal growth, and there are separate models for very small children. This is what the software shows you. This is how your patient is growing. This is the dose that you have been using. And this is the background growth chart that you use. Now, the thing about this software is that, again, I did a little exercise here. I used the Dutch growth analyzer software on one of my patients, and here is my patient. He is a full-term born male, 2.5 kilos weight, and he's IGHD, and the growth analyzer gives you, based on this data, a prediction of 10.8 centimeters per year. You put the same in iGrow, and with Professor Ranke's model, it tells you that the patient should grow about 12 centimeters. In reality, my patient grew 16 centimeters. So, if you put it here, the green bars are telling you how my patient should have grown. But in reality, my patient is growing much better. So here I know it's time to reduce the dose of growth hormone, and this then becomes much more cost effective. So you can decide the dose based on the response using something called, and one more thing, it also allows you to put the Indian data in the background. So here it remains frustrating that despite several years of treatment, your patient is still not reaching the 3rd percentile. But on Indian charts, it has already reached. So it allows you to change the background tables as well. And there's something called index of responsiveness. This is like a Z score of your response. What the patient has grown, what is the median that you expect, and then you get index of responsiveness. And if the index of responsiveness is high, this is time to reduce the dose. It's too good. In the interest of time, I'm going to miss this case of Turner syndrome, but it primarily gives you the same thing. So in iGrow model, most children respond to GH therapy as predicted. Just maintain the growth hormone dose. Some children respond better than expected. Consider reducing the dose. And when your patient does not respond, it's time to revisit the diagnosis. You look at whether your dose is right, the compliance is correct, investigate for anything else that is developing, like other endocrinopathies, other associated disease, etc. Now, my last 3 slides. So my conclusions about adult height predictions is that height prediction models that we use were developed from normal children who are not very short, not very tall. Height prediction in short children will overestimate the adult height. In short and tall children, a delayed bone age will increase the margin of error. Using updated country-specific growth chart help to correct for the secular trend. In disease situations, height prediction is an imperfect science. Please remember this. This is not perfect at all. Software built on robust models such as iGrow help clinicians to use these intricate models with use in clinical practice. With permission of the chair, we are having a growth workshop of PediCon, that is the National Conference of Pediatrics, on the 8th of January 2020. And those who want to learn more about growth, Tanner staging, and other aspects of anthropometry, please register on the PediCon website, or Dr. Ankita Maheshwari, who is the coordinator, is here in the audience. And we wrote this book, as you know, IIP textbook on pediatric endocrinology. So you are welcome to have a look at it. It's available on Amazon. Thank you.
Thank you, Dr. Vaman Khadilkar, for your insights on growth prediction models. Do we have 1 or 2 questions? Yes, sir. Can we have a floor mic there?
Overfitting because the models are separate. So probably we need to
Yeah, I agree, because I think in Bone Expert, again, the constant use are based on the European model. So they are going to over-predict the final adult height.
Thank you, Vaman, sir.
Okay.
Listening to you is always an audio treat, sir.
Thank
and today is not a different. So just as you have said, on a predicted model, if patient is, behaving better than what we have predicted, you have suggested to reduce the dose. Does it affect the final height? Patient may ask, sir, if I am giving the same GH, probably my child will grow much longer, because that is why he is with us.
Well, I suppose if you have a millionaire there, then I would still not recommend giving higher dose of growth hormone. Because see, finally, you're giving something that is pushing the IGF-1 up. And I did not show you the IGF levels in that patient, because in growth hormone deficiency in Indian children, somehow the IGF just does not rise to the expected level. But the anthropometric response is much better. Now your question is, if you continue to give higher dose, will the final height be better? The answer is yes. It will be better. But are you using the optimal dose, or are you just using an unnecessarily high dose? I would like to draw your attention to the growth response curve in growth hormone deficiency. Once you go beyond 35 microgram per kilo per day, it's flat. So I don't think pushing the dose in GHD is going to make your patient much taller. Hardly any difference.
Yeah, Dr. Vichar Lakshmi Bhatia.
Elegant as always. I just want to comment that adjusting for the Tim Cole paper, adjusting for secular trend, I think it's a moving target, because secular trend is going to change with every year. So I feel that formula is good for research publications, but not for an individual patient in our clinic.
Yes, you're perhaps right. Yeah.
Are there any questions, comments? If not, I think it's very important that we diagnose based on growth charts to initiate our evaluation. Even after starting treatment, it's important to assess and predict how well we are moving on the growth chart. And as Dr. Vaman Khadilkar suggested, that we may also, on the basis of that, adjust our growth hormone doses as well. So thank you very much for this enlightening talk.
Thank you.
Thank you.